Hi, I'm Dr. Mark Studin, and welcome to today's presentation. First, I'd like to thank ChiroSecure for providing the forum. It's always a pleasure to collaborate with them. And secondly, next week, I'd like to share that Janice Hughes will be on air. Today, we're going to be talking about emergency rooms and working with MDs and what it takes to break that glass ceiling. So let's go to the slides. Everything when you deal with MDs is about evidence-based care, and that's really, really important. And in the Academy of Chiropractic, which is our parent organization, is we strive towards clinical excellence. And we want to break the dogma of DCs versus PTs. Who's better for spine? We're not going to talk about lawyers, but the goal is to get lawyers to DCs first and hospitals to have chiropractic inclusion. That really, folks, is what primary spine care is. I want you to become a primary spine care provider. And primary spine care means, quite simply, you're the first provider for spine. That's it. First referral. But not just MDs, hospitals, urgent cares, emergency rooms, lawyers, everybody. You should be the primary spine care provider and not a physical therapist. We'll talk about that, why, in a few minutes. But first, what I'd like to do is there was a doctor in Florida who wanted to break into a hospital. And his name is Steve Canuel, and I'm going to play a little blurb with his permission. I'm going to only play the first 3 minutes of it. Let's listen.
Recording started. Hi, I'm on with Dr. Steve Canuel from Florida. Hi, Steve.
Hey, Mark, how's it going?
Things are going fantastic. So, Steve, recently you went to a hospital meeting where the hospital wanted to have a meeting with chiropractors because one of the things that I'm realizing around the country is hospitals have overlooked a tremendous resource for utilization, and that's chiropractors. And they're starting to open their eyes. So you were contacted just recently, about 3 weeks ago, I think, or 4 weeks ago?
Yeah, that sounds right.
Yeah, by one of their marketers to attend a meeting. And could you just share with us, just set up what that meeting was like?
Yeah, so they had a meeting at a local restaurant there. There's maybe about 15 or so chiropractors there. They were wanting to bridge the gap, they said, between the MDs and the chiros. They wanted to start doing some basically like continuing education classes, having us both present so we could start building relationships.
So basically they wanted your referrals.
Yeah, in a nutshell, yeah.
No matter how they slice the dice or cover it with bullshit, they want your referrals. And
yeah.
They sent their marketing person to get you.
Correct.
Right. So what happened at this meeting? What was the format like at this meeting? And what did you do to prepare?
So first of all, we dressed for success. I was wearing a suit and tie. And my wife was also dressed professionally. Most of the chiropractors, they were in scrubs, jeans. One guy was in shorts. And yeah,
in shorts.
Yeah,
you can't make this crap up, can you?
No. As the medical director started talking, he would, the other chiropractors started puffing their chest, started talking about subluxation. One guy was saying, well, you MDs, you do surgery and I have to fix them. And there just became this like argument back and forth. Me and Wendy just sat there, didn't say a word. And I told her I needed to leave early anyways, about 7:30. The meeting started at 6. So it started getting close to that time. So, I waved to him. I told him earlier I was leaving. Came up there, shook his hand, gave him my copy of my CV and said, yeah, I'd like to talk further with you. And that was about it.
Okay. And what happened after that? Now, by the way, you are trauma qualified and hospital qualified as of the time of that meeting, correct?
Yes, hospital qualified, trauma qualified.
And you were prepared. That was the bottom line. You were prepared.
Yeah, we were prepared. So a few days later, they reached out to us, the marketing, and she wanted to set another meeting in our office, We did that. It was great. We talked about Eric being out in Colorado and their neurosurgeon.
In Utah.
Yeah, or Utah, yeah. Actually played a video of the neurosurgeon that he works with out there. She was very impressed. And yeah, she went back to the hospital. They contacted us again and said that they definitely want to work with us. So we're working on setting up another meeting with the docs.
So I could the recording's over. So just to segue after that, they've had 2 or 3 meetings. One of their medical directors took them out for dinner, and the real question is, what was the takeaway from this meeting that brought them there? Well, it's very simple. They dress for success versus shorts and a t-shirt or even scrubs. And look at the second column. They're a doctor of chiropractic. He was trauma qualified, advanced training and MRI qualification. He's hospital qualified. If you're primary spine care qualified versus just a doctor of chiropractic. And I don't mean to denigrate just a doctor of chiropractic, but he came up with a concise business strategy that benefits the hospital versus the other 14 people in the room that had a strategy that benefits the chiropractor. That's the formula for success. And we're going to really dig into that strategy as we move on. Because if nothing else, I am a strategic business strategist. I have worked with hospitals all over the country, large medical groups. I consult not just for chiropractors, but for MDs. And it's very easy with what they want. So this is important. You've got to prepare if you want to work with the medical community, whether it's an individual doctor or it's an entire community. You've got to be prepared. And those 6 P's matter. Proper planning prevents piss poor performance, and that's critically important. But one of the things that I've done is espionage for referrals. And I started this back in 1996, where I paid $106,000 for a company to infiltrate the top spine-related MD specialist in my region. And I learned a tremendous amount. Those secrets equaled referrals, we're talking decades ago. And that same holds true today. What are they doing? What do they need? What do they want? And the bottom line is, what are the trends? So my job is to find out the trends. And here's the trend for chiropractic. You're going to see advertisement on benches. You're going to see spinal, what are those units? Posture units, advertisements that are cute where the dog is there and bent pens. You still see a lot of that stuff out there. Look at this cancer surgeon, Dr. Jamie Landman. You know how I know him? My wife had cancer 3 times. 3 times. If you think that I looked for the person who had a park bench as a cancer surgeon, you're out of your mind. I went and scoured and found this guy. I looked at his CV. He was incredible. It took me 6 weeks to get an appointment with this guy. Actually, that's not true. It took me 3 weeks. I had to run after him. I need a favor after a favor after a favor. And this was in 2008. And when I was going through that, in the middle of the process, and my wife is fine today, I said, why don't people run after chiropractors? Well, there's a reason for that. And the reason for that comes to a strategy, a mindset, and what is considered usual and customary in our profession. And I am looking to change what's usual and customary because it's about credentials. If you are the best of the best through clinical excellence, which has nothing to do with your ability to adjust, they'll come after you. It's about case management. Remember the movie Field of Dreams with Kevin Costner? Build it and they will come, and they do. I ran after that surgeon, and I can share with you as of this morning, in the past 9 years, we were able to get 1,360,000 additional new cases to chiropractors. We'll talk about that later on. So we get into that, but what's the strategy? It's very easy. We start on the bottom left with infrastructure. You've got to build an infrastructure of case management and how to understand that. Then you move up and you have to have documentation that's pristine and compliant. Then you need tools and you need credentials, and that's critical. Then you build your relationships. You get into the top of that pyramid. Then you start getting some referrals. Start from MDs and lawyers. Then you become the solution to their cases. Now you move over to the inverted pyramid on the top, and you're working with MDs and lawyers. And when you're the solution, not just to their case, but for their practice, because you're taking issues away from them, now they start to pay attention. And you could do plaintiff IMEs or second opinions for those lawyers, or get peer relationships when you collaborate with the MDs, and then you start teaching them. because you need to understand the latest literature in relation to spine. That's what a specialist does. That's what a primary spine care provider does. And you need access to that literature and education. Then you start, when you become their teacher, you get exclusive referrals. It'll be really hard to break that relationship. Once you do that, they become your advocate for inclusion. They bring you in ERs and primary cares and medical schools, specialty practices, trial law and bar associations. You're, game over, you win. This formula has been working like a charm. To make it simple, the first thing you need to do, infrastructures, credential, and strategy. Then you can communicate. Then you can look at reports and educational programs and case collaboration and business solutions for them. But your business model is upside down. It's not enough just to help people to turn on life, to adjust them. It's not enough, because that's brought us at best to about 7% utilization in our industry. Maybe it's bumped up to 8 or 9, but we're not much beyond that. Just think of primary care medical doctors. They see 95 to 97% of the population. So we don't, and we should be seeing a lot more than we do. But let's look at how where the problem is. And this is the core of the problem. The core of the problem is dogma. According to Monteiro et al., accordingly, chronic low back pain and neck pain are considered nonspecific in a large majority of cases, meaning the pain cannot be attributed to a specific origin or to a pathway detectable with imaging methods. That is nonsense. That is not true. That is steeped in dogma. We have another name for dogma in New York. It's called BS. New Jersey, it's even worse. But dogma is a false belief that MDs hold on to, because if it's not an anatomical problem, fracture, tumor, infection, they don't know what to do with it. We do. It is very specific, and I'll show you that later on. But what you need in dealing with MDs is they want the evidence. They want the evidence in the literature, and they want to work with peers. They don't want to work with a lowly therapist, a PT, or even worse, a chiro below the PT. They want a peer. So when we look at how it works, let's look at number one in the top left. Patient goes to their primary care provider. They complain of back pain. Doctor thinks it's nonspecific. Number two, gives them drugs, muscle relaxers, Medrol dose packs, steroids, painkillers, or opiates. None of those work. Failed treatment, off to number three, to the surgeon. Now, only 8%, a surgeon has to see 100 cases for 8 surgeries. So 8% need surgery. Let's talk about the other 92%. They don't need surgery. Now they're going to the PT. They're going to number 4. That's going to fail, and we'll talk about that in a minute. Then when it fails, they go back to their primary care or their ortho, back for another course of therapy, another course of physical therapy, which is going to fail again. And then it goes back to the final solution, which is pain management, which is legalized drug addiction. That's where people are and live, which has fueled the opiate issue in our problem. But let's tear this apart. Let's look at where the issues are. Let's look at MD primary care triage. In a recent article written by Humphreys, etc., in 2007, they stated, in the United States, approximately 25% of all primary care doctors are from musculoskeletal complaints. And it's been estimated that less than 5% of the undergraduate and graduate medical curriculum in the United States and 2.26% of Canadian medical schools devote to MSK treatment. Now, there was a paper of basic competency on MSK where the passing score was 73%. Recent medical graduates, only 18% had basic competency. Medical students, residents, and staff physicians, board certified internists, family practitioners, 20.7%. Osteopathy, 29.6%. Now, that's in basic competency. Most respondents, in another article in 2006, 92% of them said their education for musculoskeletal issues were not sufficient. Then we go even further. Weed et al. Reported in 2013 that the average annual charges for filling an opiate prescription was 74% lower with chiropractic care. They also reported the adjusted likelihood of filling a prescription for opiates was 50%, 55% lower with chiropractic than with no chiropractic care. So now we know we help with the opiates. Now we go into surgery. Again, only 8% get surgery. Where do the other 92% go? On the Cleveland Clinic's website, it says about non-specific back pain. These patients may be best served through prompt access to PT or a nurse practitioner at the entry level. When pain persists, then you go to a spine specialist or a surgeon or a behavioral problem. The Mayo Clinic says physical therapy is the cornerstone of back pain. A physical therapist can apply treatments, etc., to reduce pain. Now, I want to focus on those other 92%. What do they do? It's very, very simple. They go into physical therapy. Now watch. Physical therapy is best suited for all rehab as the first provider, except spine. Now, according to Humphreys again, for musculoskeletal conditions, where 70% or greater is the passing score, a physical therapist at the master's level and the doctoral level, by the way, master's level 21%, 26% at the doctorate level. A chiropractic student was 64%. Just simple. So we're so much better, and I think that number is way low, 64%, but that's what they came up with. So it's just about triple of any of our competitive treatments, and physical therapy certainly is a failed entity in musculoskeletal care. Why? Because if we go to Marist College and look at its contemporary doctor of physical therapy program, they're not learning to be doctors in diagnosis and case management, just more of what they do. They get 2 credits in diagnostic imaging and not how to interpret, just to understand what it is. 3 credits in cardiopulmonary management. In other words, how to manage cases who have cardiac issues with therapy. Their programs are never intended to train physical therapists to be any type of primary care provider or entry or portal of health into the healthcare system. And by the way, all of this is evidence-based. The scope of a primary care provider. You look at PT. Texas is a typical state. You've got to have a prescription from an MD. It's just simple. They may provide, if you look at number B toward 2B, PT may provide instruction who is asymptomatic related to the instructions being given without a referral to promote health, wellness, and fitness, but certainly they cannot work independently. And Texas actually got it right. There are some states that allow direct access to physical therapists without a prescription, and I believe that's a public health risk. But with the general genre or care path with physical therapists after MDs, in 2013, Matthew McCarthy and Davis and Landon reported that physical therapy back pain treatment from 1999 to 2010 represented 440 million visits and revealed an increase of opiates from 19 to 29% during the same time, with continual referrals to the same failed treatment path. According to Blanchett in 2016, medical care ended spinal-related compensation 12% longer than chiropractic, and physical therapy required 239% more time to end full compensation than chiropractic. Regarding partial compensation, medical care was 20% longer, and physical therapy was 313% longer. It's incredible. So Cifuentes reported a 32% decrease in average weekly cost of medical expense compared to physical therapy, which is better. MD is a little bit better, but here it is. The cost for managing low back pain, just managing and not fix anything, was $106 billion. $106 billion and $20 billion in lost productivity. So you look at what's going on in a failed care path. So if we look at low velocity manipulation, which PTs do, okay, and arthrokinematic studies and osteokinematic principles, it doesn't affect the release of substance P, which is a neuropeptide, which helps analgesia, which promotes healing, which does a lot of things. But chiropractic adjustment does that. Coronado reported that high velocity, low amplitude adjustment causes significant higher changes in pain sensitivity. In other words, up into the brain, okay, where low velocity or physical therapy joint mobilization doesn't work. Reed found that high velocity, low amplitude thrust and chiropractic spinal adjustment revealed unilateral, bilateral, and multi-level hypoalgesia because of central nervous system changes. Physical therapy does not. Those are the things we're looking at. Cifuentes reported chiropractic had a 250% decrease in disability duration during the first episode compared to an MD's care. Day et al. Reported that 82% of fourth-year Harvard medical students, and that's another one, failed basic medical competency in musculoskeletal aptitude. And Devouche revealed that 87% of chiropractic patients were helped, exhibited a decrease of pain, where 82% of fourth-year medical students can't even come up with a diagnosis. We're helping 87% of the people. And I could go on and on and on. It just doesn't end. It just doesn't end. Well, just as a side note, everything I just shared with you are in these 2 volumes called The Science of Chiropractic. So if you want that research and more, these 2 volumes have those. You can email me. We can offer you a discount. You go to lulu.com. Everyone's always looking. Where did you get those references? Where did you get those references? This is where you can get those references. And we've done the work for you, and it's simple and it's wonderful. But the outcome of this is a failed care path. Failed care path. So what's going to happen is you have perpetual pain, you live in drugs. Wolff's Law is going to come into effect, which is arthritis, which is degeneration, which is epidemic in our society. Now you know why, because it's a perpetual failed care path. Medicine doesn't have it right, and we need to educate them. But unless you're educated, they're not going to be educated. And it's really that simple. So to shift referrals, the MD needs the evidence. They need demonstrative proof, and that's critically important. We'll get to that in a moment. They need peers for case management. They need people with credentials in order to work with. Those are the 4 keys that you need to march without appearing to march in getting them to understand what you need to do. Now, here's another thing, and let's just look at the second paragraph. The estimated total expenditure for neck and back pain between 2018 and 2027 is $4.65 trillion to a healthcare delivery system. The estimated savings, if chiropractic treated first, would be $1.65 trillion. It's just simple. It's just simple. But that's the reason why you're not getting the referrals, because they'll lose the money. And they want to keep that in the system because too many MDs own too many PT practices. Too many drug companies want to perpetuate these things. That's what you're fighting against. It's a multi-trillion-dollar business. Now, with hospitals and chiropractic inclusion, hey, folks, just like Tony Soprano said, it's not business. It's just business. It's nothing personal. It's just business. That's the key. So when we look at, in the past, what we tried to do with hospitals is we tried to say chiropractic added service. I'm going to refer to you MRI. I'm going to refer to you neurology, pain management, electrodiagnostics, physical therapy. It's a failed strategy. We tried it because the hospitals are going to get very small dollars. That's just the bottom line. What's big dollars? This is easy. You ready? Here's big dollars, folks. One spine surgery, a 2-level fusion on Long Island, is $365,000. That's what hospitals want. They want procedures. And it's plain and simple. You want to get them procedures. So let's look at this again. A spine surgeon performs 100 examinations for 8 surgeries. It takes 3 clinical days to create that, and then 2 days of surgery. Now, the malpractice rates in New York for a surgeon is $365,000 a year for a spine surgeon, and if he has 2 cases against him, even found innocent, it goes to $600,000. What our doctors do, what I do with doctors, is train them to be neurosurgeons without a scalpel. And it's about management, it's about diagnosis, about triage. So the DC screens the same 100 and refers 12 for the 8 surgeries because we pre-screen them. Now the surgeon or the hospital can have 1 clinical day and they lose money on evaluations, and 4 surgical days instead of 2. Folks, it's always about the money. You've doubled their time. Because for me, It's not about the surgeries. I'm not trying to prevent surgeries, even though I'd like to. You need surgery, I'm getting out of the way. I'm not looking at that 8%. I'm not Don Quixote fighting against the windmill. I am focusing on the other 92 patients. Where are they going to go? I want them in my office. If they're not in your office, your philosophy doesn't mean a hill of beans. What your beliefs are means nothing. You'll be talking to the wall in a mirror. I want those 92 patients in my office so I can manage those cases, so I can get them adjusted and do whatever I want. Because when you start getting hospitals and surgeons and MDs to understand that you are the solution to their problem, they will start working with you. And if you are credentialed, just like Steve in Florida shared with you, he gave them the CV. It had pages and pages of courses which were meaningful, which worked, because it showed them that he was a peer. It's peer-to-peer. And what shows your peer-to-peer is your current E&M reports, your referrals, reading your documentation. When they look at recurring non-specific back pain patients, they don't know what to do with them. Your graduate medical education and credentials. When I train a doctor, you get co-credentialed, not just through chiropractic academia, but also through the State University of New York at Buffalo Jacobs School of Medicine and Biomedical Sciences. I've worked for almost a decade to secure that credential. Because now, when you're talking with an MD and you say, hey, I referred that MRI over, and there's a 2.5 millimeter slice, no gap, and I'm getting 2 to 3 clean slices through the disc, and I want to make sure there's a T1, T2, and a stir view to make sure when I fat suppress it, I see what we're doing. And occasionally we're going to need a proton density view. They're going to say, you're a chiropractor? Yeah. Where'd you learn that? Oh, through the State University of New York at Buffalo Jacobs School of Medicine and Biomedical Sciences. Now you just became a peer. You went from being a lowly therapist below the dog poop on the shoe of a PT to a peer. Therein lies the secret to referrals, because it's about reputation and it's about being a true spine specialist. That is the core reason why my doctors have gotten 1,300,000 and plus additional referrals into their offices over the last 9 years. And it works like a charm. And Steve Canuel was in that room with 15 other doctors. He was the only one that got a knock on the door the next day. And when they came to him, they said, oh, who else in your region is credentialed like you are? And the answer is nobody. It's really that simple. So when we look at this, there's things you're going to have to learn to document. And I'm going to go through this really fast and just give you a quick overview. You have to be able to document and the word is demonstrable, potential pain generators, whether it be the spinal cord, the fecal sac, the recurrent meningeal nerve, myelomalacia, nerve root compression and abutment, and facet and connective tissue pathology. And by the way, chiropractic lives in facet and connective tissue pathology. You've got to put it in a way that's easy to understand in a report, where you have demonstrable pain generators, where it's all laid. This is what they consider non-specific back pain. Here it is, non-specific. You've got to understand this. You're going to have to go through a little bit of training to get there. Because the worst thing you could do, the very worst thing you could do, is get into a hospital or have an MD refer to you, and then they understand you don't know anything. And the next thing you know is you're a one and done. They'll never work with you again. And that is the worst place for you to be, as a one and done. And I mean that sincerely. So when we look at making it demonstrable, there's a piece of technology called Symverta, and it's X-ray digitizing. And if you look at their spine, we digitize the spine. It takes about 1.5 minutes to digitize, and it gives you a graph. There's a green line and a red line on that graph. The green line shows pathology. The red line shows the maximum impairment rating. When I work with the MDs and I sit with them, I say, listen, you see this? This is your non-specific back pain. You couldn't find fracture tumor infection, so you just want to give them an analgesic. You want to drug them up. But look here. Look at C5. Look how far that segment is aberrantly moving. And it's all evidence-based in the literature. It goes way back to Panjabi and White in 75. And there's tons of literature now. But you can make what we do demonstrable. And when they look at that, they go, holy crap. Most neurosurgeons and orthosurgeons who do spine and neurologists and pain management and physiatrists, when they look at this, and primary care, you know what they say? I want this on every patient. How can I get this in my office? They all see it, and PTs aren't going to know what to do with it. It's critical you have the tools in order to be able to get this done. So what we do when we look at this stuff, again, demonstrative. Do you understand how to explain an MRI? Can you look at a herniation versus a thecal sac versus the spinal cord, which are the three slices we have here? These are the things that it takes not a lot of training, but it takes a little bit of training for you to become a peer and work at the peer level for knowledge, and that's the key. So when we look at this, again, it's credentials. I'm credentialing you through not only SUNY Buffalo Medical School, you're a board certified chiropractor. We work with the Federation of Chiropractic Licensing Boards. I work right now with Cleveland University, Kansas City Chiropractic and Health Sciences. So you're getting tons of credentials. You got to show that you're working both sides of the fence and you get what they need. That is incredibly important to understand. These are the various qualifying programs, and things are changing in our industry. So being trauma qualified is the new minimum. And on the bottom right is MRI interpretation review qualified. And by the way, that was just approved through the ACCR, the accreditation, the Academy of Chiropractic, ACCR, Academy of Chiropractic, Credentialing, and Radiology. It just flew out of my head, I'm sorry. So, and also the credentialing board for DAC bars. So the ACCR has approved the language. The universities have approved this language within our academia. It's taken a lot to get here. Hospital qualifier, you got to check that box because hospitals need doctors to be qualified. Not through JACO that they require, but we're meeting a requirement that they have. These are the levels of things you need to become primary spine care qualified, to be the first referrer. And this is real education. I mean, you're being taught by Harvard-trained neuroradiologists, by Albert Einstein College of Medicine-trained double-boarded vascular neurologists, by neurosurgeons from the State University of New York at Stony Brook, and on and on and on, in conjunction with the head of people, in chiropractic, and everything is academic-based. So this gives you, once you get qualified, it lasts you the rest of your life. It never goes away. This is what makes your competition irrelevant. And your competition are not other chiropractors down the block. I mean, they're clueless. Your competition are ortho-neuros and neurosurgeons, and primaries and PTs. This makes your competition irrelevant and allows you to work at a peer level. Here's where your journey starts if you want to learn more. Just go to the academyofchiropractic.com. You're going to learn how to build your infrastructure, develop a strategic business plan, and then get the tools, because clinical excellence will drive your success. And here's what it looks like, folks. Remember I said that 1.6 million, 1.3 million new referrals? Our average doctors get between 15 and 25 new cases a month, mostly PI, and their take-home pay after taxes goes up about 61%. That's across the board, and I don't care what state you're in. So listen, I'm pretty much done. I'd like to thank you. I'm a little bit over my time. If you have any questions, please email me. This is my email address. Call me. I love this stuff. I'm happy to chat with you. I'm happy to talk with you. You want to learn more, go to the academyofchiropractic.com. Call me, whatever you like. Folks, again, I'd like to thank you so much. You'll see Janice Hughes next time. And again, thank you, ChiroSecure.